And to what extent are current population level cholesterol control efforts translating into actual achievement of guideline recommended LDL-C and non-HDL-C targets?
That's a good question. From a primary prevention standpoint, and also just thinking about what we can do at the population level, we will often begin by lifestyle modification. Leading a heart healthy lifestyle is something that we encourage for all patients. And organizations like the American Heart Association, for example, has something that's called Life's Essential Eight. I believe some of my colleagues have spoken about that previously. It's actually a very commonly used tool that the American Heart Association promotes that talks about 8 different things that we should be focused on when it comes to preventing heart disease. One of those things is lowering cholesterol if you do have a elevated cholesterol, but the lifestyle factors include incorporating more physical activity, eating a heart healthy diet, making sure you're getting good sleep. If you smoke, quit, and those sorts of things. And so I think we are becoming more cognizant of the things that we can do on our daily basis just to prevent the development of heart disease.
Mm. Um, and I want to switch over just to talk a little bit about guidelines, risk assessments, and targets. I'm wondering what are some of the key changes in the 2025 ESC-EAS focused update on dyslipidemias that you think practicing clinicians need to kind of focus on?
Right. So the European Society of Cardiology had issued some guidelines in 2019, I believe, and then they did a focused update this year where the main things that changed were the targets for LDL. So, for example, depending on people's risk, if you're at very or extreme risk, I think is the category that they classify, which I think is about like greater than 20% risk of cardiac event, plus having had a history of cardiac disease or peripheral artery disease. For those folks who are at extreme risk, they recommend getting LDL cholesterol less than 55, I believe, or even lower than that. And so, really moving towards, as I was saying before, aggressively treating LDL cholesterol and lowering it as much as possible. Another thing that they talked about in the updated guidelines were some of the newer therapies that we're using, including the PCSK9 inhibitors, which help to lower cholesterol, and thinking about other adjuvant medications that you can use in addition to statins or instead of statins for patients who are statin intolerant. And then one other really big thing that they talked about in the ESC guideline, and I think that our American guidelines will probably incorporate as well, is measuring lipoprotein little a. So there's been a lot of data that's been coming out since the 90s, if not before, but we know more and more about how LPA is linearly associated with cardiovascular disease, and that's irrespective of LDL. And so, at least screening for LPA as a risk modifying effect in all patients who are at risk for heart disease.